the idea of quality improvement is that it becomes a cultural change. And so everybody has to be on board with that, and making sure that people understand, the new employees, for example, the new staff, as well as the old ones who may have lapsed, in terms of their ongoing thoughts about quality improvement and how they can make things better. All right, so we're kind of onboarding quite a few more people here, so I think we can get started. So this is, again, our march towards the 10 steps of QAPI. So we're in the mid road of this program. I just want to point out that today is actually the first of the series now for the national program for their videos and their video resources from the Institute for Healthcare Improvement. As you recall, everybody who's in this program has gone through phase 1. We had those 16-week sessions of how to gear QAPI towards improved infection control in long-term care. Now this is kind of refining our skills, sharpening our skills. And what we had been doing for the last 5 sessions for what we call now phase 2 is to really look at the building blocks of QAPI, and we will continue to do that. But now we're going to start infusing some of the national curriculum that has been provided by the Institute for Healthcare Improvement. So you'll see the first video today as part of that series. Okay, may I have the next slide, please? So just wanted to find out how folks did from your structured walk rounds. Does anybody want to put in the chat box if they learned anything new or different from their walk rounds, and and if so, what that item was? If you could just share that in the chat box from your last week's walk rounds, just if you can share that with the group in the chat box, that'd be wonderful. And I also understand that we have about a half dozen or more root cause analysis submissions. So is that about right, Michelle?
Yeah, we have 6 good ones. We have a few other that are still learning and working on it, but yeah, we've got some submissions of those. So thanks so much for sending those in.
Yeah. That's good to know. So if you have not submitted your fishbone analysis regarding social isolation evaluation, is what's working, what's not working, that'd be great. So again, just as part of the homework or action plan that we call it in these collaborations. So yeah, good. So people are making adjustments, with in the chat box, looks like some of the PIPs are being adjusted, which is good. That's the whole point of this program, is to try to streamline all of our efforts, right? So technically, everybody should have been able to has completed their QAPI strategic plan as part of those questions that we sent out from CMS, and so you're all done with that part of the project, for 2021. So congratulations on that. Yeah, the very tired of COVID seems to be a recurrent theme, no doubt about it. And that's as the British say, chin up and carry on. I think we need to keep reminding ourselves and providing different reinforcements, for that fatigue, right? I mean, this is a marathon. This is not a sprint. So I'm just reading a few more here. I see. Yeah, Cindy's talking about family related from the outside and young staff not staying home, even though they are positive. Yeah, I agree. And it's sort of like this downplaying of symptoms. Again, it's like, you got runny nose, scratchy throat. Oh, that's my allergies. Maybe not so much your allergies, right? So I think we just have to be mindful and remind each other of that, and recall back, in terms of this COVID fatigue, the PIP fatigue. I really look back to what we talked about before with the buddy system. Making sure we reinforce the buddy system, and having those buddies identify people who are just maybe perhaps lapsing in their PPE, which is what we're going to discuss today, post-vaccine. So good. Well, thanks for that feedback. I encourage everybody again to do structured rounds. Part of quality improvement really benefits from checklists. And so it's just like what the pilots do when they get on a plane. The difference between when they didn't use checklists and the number of crashes that occurred per year went down dramatically once the airline industry and the FAA sent out, checklists, because they knew that they could check everything off and not forget things. All right. Why don't we we have a poll here, I believe is the next slide here.
This is Kelly. I have a quick question related to these outbreaks, and I think Cindy had indicated some of the young staff not staying at home when they know that they're sick. What kind of sick leave do staff still have? After the year, there may have been a lot that have been out a significant amount of time. Maybe they were positive already. You guys been able to replenish their sick leave over time, or do you have a specific COVID sick leave in order for them to take off? I feel like that may be a contributor to people not staying at home because they need the paycheck, essentially, and if they don't have sick leave available.
Yeah, good point, Kelly. I don't know if anybody wants to respond to that in the chat box or unmute yourself and just comment about the either used up sick leave or not. I know in our training program, in our geriatric fellowship, we have basically both of our trainees used up all their sick time. So we're kind of allowing them to, use whatever additional sick, we're giving them more sick time basically.
Yeah, I see some people have responded that, kind of after the vaccine, it's changed a little bit. So I don't know if that's just a new challenge, and how do you address that? I don't know that I necessarily have the answer, but it's just something to think about.
Yeah, and I think there's a really good point made here in the chat box about people using symptoms to their advantage for not showing up for work. So yeah, that's a delicate balance. I'm not sure if any of our faculty and mentors here have any ideas about how to balance that off.
I can say when I was still in the facility, depending on what was going on, sometimes we would have staff come in for us to do an assessment of some sort if they were one of those chronic call-ins with symptoms or illness, to really determine if it was false or not. I know that's kind of hard in the COVID situation, but
yeah, it's sort of like for me, I always take personnel management as like baseball. You look for patterns. Strike one, strike two, strike three, and I guess you just have to look for patterns. So if somebody's consistently using COVID symptoms that are not, matched with reality, there has to be some sort of process for vetting that. Yeah, and there's the difference between the vaccinated and the unvaccinated. So I was just reading Sabrina's note here. However, if not vaccinated, we still have to treat as though they have it and go through all the testing. Yeah. Good. Okay. Yeah. Well, thank you for those reflections on that. Like I say, I think the pattern of people taking off in of itself is something that needs to be addressed on a one-on-one basis. So that's about the best I can offer on feedback on that. Today's agenda is we're going to review the newly launched Institute for Healthcare Improvement curriculum. So there's a short video. And then we want to get a survey because this is a little bit more your choice. You know, before all these were prescribed, you know, each week we had week 1, week 2, they had a topic assigned to us. But now we have a little bit more flexibility. So, you know, the power is in your hands to choose what you want. So we'll have a polling on that. And then we're going to talk about the steps 5 and step 6, you know, for the QAPI steps. And then our continuation of our PIP, implementing what we decided on a couple of weeks ago, focusing our current PIP on resolving or improving social isolation. Okay, next slide, please. So you can go ahead and launch the poll here. Okay, so we have the poll up here. The first question: which of the following topics would you like us to address in upcoming sessions? You can pick the key ones that you want. I mean, you can pick all of them. So go ahead and fill those out. And this will also, by the way, this will give you a clue as to the topics that are being covered. We'll cover all of them. What we want to do is kind of get the most important ones to the group and get those going firstly. And then the second and third questions relate to our what we call action plans. You know, so we try to end each session with some type of action, or, you know, if you want to call it homework, that's good too. Okay, so I think what we can do is we can share these results later. I think we'll just collect them and then send them out later rather than review them currently. So why don't we move to the next slide? And I believe that's the video. So we can go ahead and play that. And I'm going to mute myself while we're playing the video here.
Hello, and welcome to the PPE Guidance Post-Vaccination Strategies module. This presentation, key information on ensuring the healthcare workers apply excellent infection prevention practices post-vaccination. The key is the consistent and ongoing use of PPE practices that are truly alignment with local, state, CMS, and CDC guidance in order to give good direction for all staff to follow. Appropriate PPE use is essential and is a core COVID-19 infection prevention practice. This is not new, however, needs constant reminders and vigilance for adherence. As we know, PPE practices are that key strategy as nursing homes implement and maintain their post-vaccination practices, aligning with those core COVID-19 infection prevention practices. PPE supply and appropriate use continues to be a priority area for all of our centers. And it's, again, that core COVID-19 infection prevention practice to reduce the transmission and spread of the virus, and continues to be an opportunity for improvement across all settings. Whether your nursing home residents and staff are 100% vaccinated, PPE guidance must be followed until further direction is given. We know that PPE misuse or the lack of use is one of the contributing factors to the spread of COVID-19. Although this is not new to any of us, we know the importance of stressing to our staff what is and what is not PPE. That is really key to part of our post-vaccination strategies. When re-educating your staff on PPE, it's important to remind them as to what is approved PPE, the types of PPE that you're currently using in your facility, how to use the PPE, as well as what is not considered PPE. So again, as you can see here on the slide, these are the approved types of PPE for nursing homes. So now is a good time to remind staff of which PPE is required in which situation. Again, in alignment with current guidance.
The Centers for Disease Control and Prevention and the states have identified what they call PPE alternatives when facilities have exhausted their supply, to include things such as you can see on the slide, cloth face masks, bandanas, scarves, rain ponchos, and more. These are not considered PPE, and it should be clear that the staff understand that these are PPE alternatives for use only when all PPE has been exhausted. Solid post-vaccination practices include proper PPE use and handling, and adherence to the guidance is key in risk mitigation. We want to be sure that staff have proper use and handling of PPE. So having those policies and procedures, signage, trash bins or receptacles in the appropriate locations. And for shortages, if PPE shortages are anticipated or exist, then the facility will need to implement optimization strategies. And while CDC has specific guidance, please be sure to review state-specific guidance as it relates to PPE as well. While PPE is more accessible than it was a year ago, many providers find themselves still needing to optimize their supply. So we want to remember to review our current inventory and compare to the burn rate. Now, align your data, inventory and burn rate with community prevalence. And there are now 2 versions of the PPE burn rate calculator on the CDC website. One is for large companies with complex inventory needs, and one is preferable for smaller companies. Determine the potential needs, as PPE is needed and is not contingent on vaccination status. So now is the time to review the PPE optimization policies and update them as needed to align with the most current guidance. We want to spend a few moments on face mask use, misuse, fatigue, because face masks are a key strategy in post-vaccination practices in the centers. The day-to-day realities include staff not donning and doffing properly, touching their PPE without hand hygiene, heat exhaustion from not wearing or from wearing PPE, not wearing PPE correctly, and more. And it really is everyone's responsibility to coach, support, speak up when they see something that isn't according to policy. So we know we have to wear a face mask regardless of vaccination status. All staff caring for residents must wear the face mask. All staff entering the nursing facility must have donned an appropriate face mask. Visitors must have appropriate face masks. The CDC also provides information about strategies to improve both the fit and filtration.
And additional reminders for our staff is that, remember, both your mouth and your nose should be protected. Do not wear a respirator or face mask under your chin or store in a uniform pocket. And if you must continually adjust your mask, it does not fit properly, and you may need to request a different type of mask or brand. So it's important to continue to remind our staff that the primary mode of transmission from person to person, when an individual coughs, sneezes, speaks, and even, sings, it's important that all staff to understand that the environment also plays a role as well. So as the COVID-19 public health emergency continues, so does the potential for compliance fatigue. Face mask fatigue is not isolated to one state, a type of facility, an organization, or just to one staff member. It's a reality that will require constant re-education and monitoring for appropriate use. And this is for all PPE use as well. So again, ongoing audits and at-time, real-time education is important to control the spread of COVID-19.
Healthcare delivery requires close physical contact between residents and staff. However, when possible, physical distancing, which is maintaining that 6 feet of distance between people while using appropriate PPE, is that important strategy to prevent transmission. Both CDC and CMS have provided guidance to reduce the risk of COVID-19 outbreaks, including implementation of that social or physical distancing, which is one of those core prevention strategies. The guidance has not changed post-vaccination. Again, physical and social distancing and PPE are those key strategies. So for staff, we want to remind staff to practice physical distancing and wearing that source control, even when in break rooms or common areas. For residents, remember physical distancing with any communal dining and group activities. Also, any social excursions outside the facility, we're going to want to remind residents and their families and educate them on the potential risks of public settings, particularly if they haven't been vaccinated fully.
And PPE, again, must be part of your center's visitation policies. So per the guidance that's out there on visitation, we know that we should implement specific outdoor, indoor compassionate care and during an outbreak guidance with and align that with our visitation policies. So remember, As leaders, we need to communicate and update staff on those policies and align it with the current guidance that's in place. Post clear and concise instructions on the use of PPE for visitation and make that PPE accessible. And again, location based upon your policy, visitation must be conducted in accordance with current guidance. So staff should monitor PPE adherence by all parties, including visitors, residents, vendors, clinicians, and staff. And again, of course, the adherence to the core principles of COVID-19. So we know education is never one and done, and education is available through the CDC for long-term care staff. There are many educational resources for PPE education, including CDC, AHRQ, Project ECHO, CMS, and they can be viewed at any time, anywhere. So remember to be creative, make it relevant, and make it ongoing.
Surveillance of PPE use is essential in nursing facility post-vaccination practices. This is not new. However, it is the process for identifying any gaps in performance, pinpointing education needs or process changes, as well as identification of PPE shortages, inventory concerns, and the determination necessary of actions to improve performance outcomes. We will want to select a tool for overall PPE use, PPE during visitation, it could be PPE during vaccination, establish the method of collecting, determine how frequent you're going to provide the auditing, select who will be the auditors, a team approach is excellent, and then review your audit standards.
So in summary, the key points that we discussed today included really the importance of PPE in your post-vaccination strategies. What is and what is not PPE, PPE use and misuse, also PPE fatigue, face mask reminders, optimization strategies, and really looking at PPE as well as physical distancing and also PPE with visitation. So the need for ongoing creative and engaging education that we talked about is really key and important, and it aligns with your updated policies and procedures. And surveillance processes where they're monitoring and auditing and identification of quality improvement activities. Again, this is very important in part of your overall post-vaccination strategies. So we want to thank you again for attending this presentation on PPE protocols for post-vaccination practice.
Okay, very good. Were there any questions that anybody had about that video? I think my take-home lesson was basically needing to readdress these issues that we're all dealing with in terms of placing PPE properly. And, you know, there was an interesting comment from one of the news outlets that was talking about the disinfection process is being out of proportion to the actual, aerosol spread. And so really being mindful of the, the masking hygiene is just so critical. So I put in the chat box, and we'll move on here shortly to the QAPI plan development, but I just wanted to kind of throw it out to everybody to consider strategies for dealing with staff on both ends, the underreporters and then the overreporters. And thanks, Sabrina, for your commentary that, you do encourage the staff to go to their primary care provider and bring a doctor's note in that case. By encouraging that process, it seems like it reduces the number of individuals that are perhaps overstating their symptomatology. But again, I feel because I've got people coming into clinic with nasal congestion, and my nursing staff is going crazy on me because I'm going like, we got to do a COVID test. They said, well, they just have sinuses, and it's they've been vaccinated and they've got sinusitis, and it could be COVID. So we just have to, like I say, maintain our vigilance and going forward. Okay, Kelly, and you and Michelle want to take over, hand off here?
Yeah, sure. I'm just going to very, very quickly go over these next two steps in the QAPI plan because they are things that we've already probably addressed, but I'm just going to touch on them because they're the steps in the process. That step 5 from the QAPI at a glance document is actually building your QAPI plan for your whole facility. Even if you are part of a corporation, there does need to be a specific QAPI plan for each facility, which of course can be very similar and guided by corporate principles, but there always are going to be differences from building to building, from the clientele that you take care of, and that needs to be addressed in your specific QAPI plan. This should be considered a living document that you may revisit as your facility evolves. And as I said, next week, addressing some of the things that we've learned and changes that we've had to make during the pandemic, make this probably a good time when you have a few moments to take a look at that QAPI plan for your facility. Tailor it to your specific facility, all the units, the different programs you have, the resident groups that you have. For example, if you have a memory care unit, if you have a TCU, if you have a specific palliative care program, think of all of those things. Think about your range of residents. Do you have younger residents? So you may need to be continuously adapting to develop a distinct plan for quality of life for those residents. Next slide. I just have some links on here that'll go out with the slides that are tools for helping you build your QAPI plan. It's actually found in the QAPI at a glance in Appendix A is a resource from CMS. The Great Plains Quinn also has a how-to guide for writing that QAPI plan and a fillable format template that you can just write right in. If you are working on this or need to review it and want some help, please feel free to reach out to any of our team members on that. Next slide. And so as you're working on building that plan and readdressing it, we want to just make sure that everyone's aware of it. We want to communicate that. And as you're communicating and as you're building it, continue to keep in mind those key principles, your mission and vision that we talked about in step 4. You want everyone to know about your QAPI plan, any revisions that you're making. And this is just like it with anything else, like they just mentioned with the PPE. It's not a one and done. It's often and repeated and in multiple ways because people learn differently, retain differently. The goal is that widespread awareness of their QAPI plan and specifically your QAPI initiatives. So it's not one single exposure to that. We want to train through our dialogue, through examples, through exercises, especially consider your home's own experiences with residents and caregivers to learn. So for instance, if you've had an incident where one of your CNAs brought to you the fact that they noticed that laundry is starting their shift earlier and earlier, they're coming at 6 a.m. and that carries the sound of that squeaky, noisy cart onto the floor while residents are still sleeping, and this has caused people to awaken early, and we're seeing a need for many transfers all at the same time, and now an increase in falls. Share this example with your other units and other disciplines that we have this culture that we can all speak up, and what a great opportunity to learn and come up with new ideas. This is all part of QAPI. You want to talk about those hard questions, things like how do we balance issues of safety with resident choice and with resident autonomy. These type of questions don't often have easy answers. But QAPI does help you open up this for discussion and deeper thinking, and welcomes all opinions and all thoughts. Include your residents and their families in your awareness campaign. Share examples of the improvement efforts that you're making. Consider complaints. I know we all get them, but consider those as a valuable way of identifying what's going on, It might help you with more generalized concerns that are in your building. Don't just say, oh, they're just complaining again. What do we do about this? All right, next slide.
Michelle, can I jump in real quick on the building the awareness? If you all could reflect back in phase one, we watched that really brief video or vignette of the CNA noticing that there was an issue with a resident when he was watching the birds and he had a fall in the lobby, and how that CNA was crucial in the carrying out QAPI processes. That really is a good illustration to the staff that this is why you're critical in this program and this is how you can contribute. So I think it's important to be able to show them something visually sometimes. And so if you guys, Sarah or Michelle, I can try to look for it too, if that video should still be posted on the Dakota website for you guys to pull and share with staff and even families and residents. It's a real good illustration of that.
We actually had it in chat last week, Kelly. So just perfect timing. And I believe it did go out with the follow-up email, but yeah, we can, and so therefore it's probably posted on the website as well. So great example. Thank you. All right, so we're gonna go into our ongoing PIP here with a bit of a focus on PDSA. Let's go to the next slide. And Allison, are you with us?
I'm here.
Great. I am showing, this is Rosewood's performance improvement project addressing social isolation. As we've been kind of going through each week, wish it did last week. We're gonna just show all of the pre-steps that we've already done. Just show it once again as a reminder of it, and then just to show a little bit of the difference of what Rosewood is doing when they look at their areas of improvement. So Allison, if you want to just go ahead with what you worked on.
Yep. So we developed our SMART goal after looking at, the interviews that we did with our 12 residents. And so our goal became to reduce the percentage of residents interviewed who reported 3 or 4 to question number 1 to 25% or less by providing facility-wide and or individualized interventions that address companionship by 6/5/2021. So the question number 1 was, how often do you lack companionship? And we found that we had a higher percentage of residents who reported lacking companionship when we did those interviews. So that's, we just wanted to focus on one specific area that we can make an improvement in versus looking at the whole assessment and trying to take on maybe too much at trying to address all those different specific areas that contribute to overall loneliness or social isolation. So that's how we came to that goal. So we did our fishbone diagram, trying to get to the root cause of why residents are feeling lonely or lack of companionship. And then once we did that, we did our brainstorming. So our group, our PIP squad, is made up of myself, Chelsea Ertl, our DON, Liz Letnick, our Chief Clinical Officer, and then Stacy Kova is our care management coordinator, and then also the care managers within our building. So we did some brainstorming and came up with some thoughts about what we could do to apply new interventions to try and combat the loneliness and the lack of companionship in our residents. And so after doing that, we met actually just yesterday to discuss some potential systemic changes that we could make, kind of moving away from just looking at each individual resident and their specific care plan and trying to look at the facility as a whole and what things we could do differently there to try and address the social isolation and loneliness. So I think if you go to the next slide, we have that piece on there.
Yeah, our next slide is actually your guys' fishbone, which
Okay.
show that briefly there. I think you kind of covered it, but anything you want to highlight that you noticed there?
So just working through the different areas that we looked at for barriers or problems that can contribute. we focused on our policies and procedures, and mostly that's related to our COVID-19 visitation restrictions. Plays, because of our location, we haven't been able to have outdoor visits because of the colder weather. But hopefully soon it will be warm and we can resume doing some of those. Restricted outings to essential appointments only, restricted visiting hours just because of having to screen those visitors and do testing with them if we need to. And then one thing we talked about was residents don't know what new staff look like, because if staff have started since the pandemic, they've never seen them without a face mask on. And so we felt that that's something that could be a barrier to creating a meaningful relationship with the staff. If you can't see someone's whole face, you don't get a good idea of, and I think we talked about this before, facial expressions, really trying to use your eyes to express your emotion. But it's still not the same as being able to see someone's whole face. So that's something we talked about with regards to people. And then communication, we've had frequent changes in our policy and procedures. And so trying to keep up with keeping our residents and their families informed, as well as the staff, is just a lot to stay on top of when we're constantly changing how we're doing things. So overall, the outcome was that, COVID restriction in long-term care has led to loneliness in our residents. And we identified that we need to work on ways to work around those restrictions and still maintain resident contacts with others. So
that is such a great point, that residents don't know what any of your new staff look like. And and in long-term care, we do have a lot of new staff coming in all the time, and you guys are a big facility. So definitely good point. I'm just going to go on to show for the next two slides. We do have, because the area we're talking about today is the Plan, Do, Study Act, which is really the engagement part of our work here. So I just pulled out a couple of PDSA worksheets that, if you need to think through the process a little bit more than what's just on that PIP document, there is a great worksheet from IHI that walks you through the steps of how you plan each test, what you're studying to analyze, and what your next steps are going to be. And additionally, the next slide is a worksheet that comes from CMS. And this is specifically looking at nursing home QAPI work, but they have a template that you can use, again, to just think through those processes as you're going on to next steps, and helps you, ask some questions if you're not being able to think through that whole process. One more thing I just want to quick mention on what, Allison focused on at the beginning when they're deciding what to work on. This is really key in true science methodology, is to start small. And so they looked at just even one question, the question that was answered the most as needing, what they saw as needing help. They only did a handful of residents. I think it was 12 residents. So that was small. Plus what they decided to focus on was that one question, starting small and learning from there. So great job. So we'll go to the next slide, which is actually their Plan, Do, Study, Act. So what they're starting their plan and getting started. So go ahead, Allison, if you want to just cover that.
Sure. Our first item was to review the care plans of the 12 residents interviewed for current interventions to address their psychosocial needs in regards to isolation. And so we have care plans since the beginning of the pandemic for all of our residents, that psychosocial impact of isolation, potential or actual. And so we just wanted to see at a baseline what interventions they have in place already for just those specific 12 residents that we interviewed. And then look at what interventions specific to the resident we could add. So we're kind of still finishing that part up. So our start date for that was 4/16, and we don't have a completion date yet, as we're still kind of working on that. And then our next item was to meet with the care managers and myself to discuss ideas, like I said, for facility-wide changes that we could make to address loneliness and lack of companionship. And so, like I said, we did meet yesterday, and so I haven't updated this form. I updated it myself, but you didn't have the updated one. We just added some different ideas that we brainstormed. Were a small men's group because we have some younger men and a couple of other men in the building that we feel would benefit from getting together in a small group and being able to develop relationships and have that companionship together. Using our screen in our meeting room, our fellowship hall, to display library stories. So the local library offers some stories that residents could view on the screen, watching YouTube videos of musicians. One idea was a polka party that you can watch on a YouTube video. So those are some of the ideas that we brainstormed for just bringing residents together, and also trying to keep them connected with their families. Right now, that's so difficult because of the restriction with visitation. So if we can try to develop relationships between the staff and the residents to the residents, that might help with that lack of companionship. So what we decided at our meeting yesterday is that the care management group is going to pick 2 of those ideas that we brainstormed and develop a plan to roll those out, and for sure include the 12 residents that we've interviewed in those 2 activities, and then look at rolling them out further if we find that they're effective and enjoyed and able to be conducted in the building. So that's kind of where we're at with our plan right now. So we'll meet again in 2 weeks to finalize the plans to trial those 2 new activities and go from there. And then under the study and act portion, our baseline measurement was the 41.66% of residents who reported a 3 or a 4 to question number 1. And so after we implement those 2 new activities, we'll re-interview the 12 residents to see if we have an improvement in that percentage.
Wonderful. Yeah, and that's so part of the study and act area, is for those metrics. There's another portion of it that is still up with your actual plan portion. And so, that is where you're evaluating how successful some of those interventions were. Did it work? Did it not? Were there some portions of it that worked so that you can adapt it, and then see if we want to spread it further throughout our facility. So those are great thoughts. If anybody has any questions for Allison, feel free to unmute and chime in or type in the chat. I did ask Allison just yesterday if they have thought of music and memory as a potential intervention. I know there's a lot of facilities that do have music and memory, but I think some of it has kind of gone to the wayside during the pandemic. The reason it's so much in the forefront of my mind is that we just got notice this week that we will have additional funding for more facilities to do music and memory. And so we will be using, we'll be doing some educational things and support for those facilities that have already been using it, but also can bring on some more. So I just wanted to throw that in there. I don't have anything developed yet, but just the thought.
To answer your question, Dr. Jurvich, we used the one that was shared with this group. So I believe it was a shortened version. We had 5 questions on there. Yeah, so that's the one we used for our residents.
Yeah, thanks, Allison. One of the things that can come up from this is that if additional facilities use that shortened or abbreviated form, and then you find that there are trends, toward, amongst the group, then that could be a collective way of saying these are the most important questions that we need to ask, and you can refine those forms even more. So you may end up using only 2 or 3 questions rather than 5 or 6, as an example. If you get hits on those levels 4 and 5, on question 1 is the most important one, then maybe that's the one that you use as your metric. So very good. Well, very well done. This is superb.
I do have one more very short video that's from IHI on the PDSA that I thought I would share. It's only 3.5 minutes, so we'll go ahead with that.
So let's apply the PDSA cycle to an actual example. Let's take, for example, discharge planning. That is, getting a patient out of the hospital on time when they were told they'd be discharged, which pleases the patient, the family, and the next set of patients that need to come in. So, what is our plan? The first plan aspect that we're going to do is that we've worked with the team to develop a new discharge planning form. Now, this form is a task that has to be done in order to achieve a test. And oftentimes people get confused between a task and a test. The test is going to be taking the form and applying it to a patient. So now this form has check boxes. It has pharmacy. It has discharge planning instructions, education, other things that are needed. Now we're going to do it. That is, on next Monday, we're going to get one of the discharge planning nurses, Tom, to take this form and apply it to 3 patients. We're not going to do it on all 50 patients. We're not going to do it on the whole hospital. We're going to start out with a small test. 3 patients. Tom's going to take the form and use it with these 3 patients. We're going to get feedback then. We're going to study. And Tom is going to come back, and we're going to get feedback from Tom on whether or not the form worked. Were things easy to fill out? Did he have to look all over the place? Did the flow of information work well? So Tom's going to give us feedback. Then we're also going to get feedback by keeping track of the % of patients discharged by 11 o'clock. And we're going to keep this little run chart to look at our progress over time. And as we do more tests, we're going to accumulate more data. And eventually we'll be able to see if, in fact, this form and what goes with it is actually improving the % of patients that get discharged less than 11 a.m. Then we're going to act. We're going to take the feedback from Tom and from our data, and then we're going to think about the next test with more patients, maybe on a different unit. Maybe now we're going to take it, instead of just from 3 West, we're going to take it and apply it to all med surge floors. Now, when we've tested under different conditions, and we're now accumulating, we've tested it with 3, 5, 10, 15 patients. At some point, after we've tested under different conditions, we're going to be ready to move to the next phase, which is to implement. That is, implementation of the test, in this case the form, to all units. But we wouldn't want to do that until we've tested, especially under different conditions. And finally, once we've implemented, we'll be ready to engage ourselves in some spread. Let's say that we are part of a system, and that system has 3 hospitals. So we've been testing it starting on 1 unit, Tom's unit. Then we're going to go to this hospital. Then we're going to move to the next 2 hospitals and spread that has been tested and documented. But it all starts with our PDSA cycle and allows us to give a framework for testing one idea against a group of patients that eventually will be allowed to implement and to spread on a regular basis. It all starts with the testing of PDSA.